Hi, myself Dr. N. Komagan Prabhu, Associate Professor from Department of Oral and Maxillofacial Surgery. I would like to give you an insight on the local flap buccal pad of fat, which is a hidden treasure in augmenting soft tissue intraoral defects. It was first described by Lawrence Heister, and it's also called as glandula moralis. And since he was described, it's also called as Bichat flap. It's used as a pedicle flap for the oral reconstruction. It was first described by AGD in the year 1977. So what is buccal pad of fat? It is an anatomically rounded, a biconvex structure, and it gives a good contour to the face. It's a large part of your mid-face region. Coming to the process involved, it is having a central body with four processes, namely the buccal, the pterygomandibular, pterygopalatine, and the temporal, all the four branches. It is basically located between the buccinator muscle on the medial side, the anterior margin of the masseter muscle, and the mandibular ramus and zygomatic arch, which is found lateral to it. The entire buccal pad of fat is lined by a thin capsule. The average volume it accounts to 10 ml with a mean thickness of 6 millimeters. Coming to the surgical significance, it is mainly innervated by the buccal and the zygomatic branches of the facial nerve, where it's closely in line or approximated with the parotid gland, which is lying lateral to the fat pad. Very importantly, it should not be injured during the flap mobilization. You can see it in the figure. This is the Stenson's duct of the parotid. The main functions of the buccal fat pad being it cushions the adjoining structures, mainly prevents the neurovascular injury. It acts as a gliding pad for the masticative muscles and helps in mimicking the muscle contraction. And in babies, it aids in suckling and gives cheek fullness. The blood supply to this region is highly vascularity. Basically, the buccal and the deep temporal branch of the maxillary artery supplies this, and also the transverse facial artery, the inferior buccinator artery, a branch of the facial artery, and the venous drainage being the facial vein and pterygoid venous plexus. Because of the rich vascularity, the advantage being it heals quickly. Rapid epithelialization is observed within a time span of 4 to 6 weeks itself, when it is used as a long pedicle flap. The applications in the oral cavity includes it aids in the closure of surgical defects following tumor excision of T2 types of 2 to 4 centimeters. After excision of leukoplakia and even submucous fibrosis, it is found to be very effective. And in closure for primary and palatal clefts. Again, during accidental encounter, when we do an extraction, if there is an oral-enteral communication, it aids in a fistula closure or a communication closure as well. So coming to the experience with buccal pad of fat. So here is a case where an immediate extraction was done in a 65-year-old patient. Because of its close proximity to sinus, the palatal root got communicated to the sinus, so which was noted after the removal of the second molar. So what we did was we immediately procured the buccal pad of fat for the closure. We made a stab incision of length 1 centimeters through the periosteum near to the tuberosity zone. So it's basically to a upper buccal sulcus region after elevating the flap completely. Next, the buccal pad of fat, it is teased out towards the defect zone. You can use a low power suction to slowly tease it out to the defect size. First, the body and the buccal extension is teased out. By using a gentle pressure on the external side of the cheek, you can pressurize that and then you can bring it to the surgical zone. You only grab the distal aspect of the buccal pad of fat so that you don't damage the blood supply. And the base should be preserved, as it should be wide enough for the vascularity to be maintained, and do not suction the flap completely out. Okay, should not be stretched, so that when it is stretched too much, it can lead to perforation. So after the procurement, and then it is finally closed into the defect site. So what you can observe is After a period of 3 to 4 weeks, a nice epithelialization has happened. Even in a week's time, you can note the good contour. Another technique of a combination technique is employed in another 45-year-old patient, woman patient. An accidental communication was made in the socket of 1/6. Here, a combination of buccal pad of fat and buccal advancement flap was maintained. How it was done is, we follow the routine protocol of procuring the buccal pad of fat, and it is teased out and it is sutured to the socket zone. Then a separate buccal flap was made and the flap was advanced over the buccal pad of fat. So it actually protects the fat layer. So here you can see the initial advancement of the buccal pad of fat, which is tunneled beneath the buccal mucoperiosteum and then sutured to the palatal extent, and the buccal flap is taken as a flap entity and then it is closed over the buccal pad of fat. So it is a case where we tried the buccal pad of fat over a following an excision of a fibrous band in a submucous fibrosis case. A small lesion of size 1 by 2 centimeters, which is actually in the line of occlusion of 1/6 and 4/6 was there. So after we excised the fibrous bands, the buccal pad of fat was used to close the defect. This is a surgical picture wherein after the fibrotomy of the bands was done, the excised surface was observed and then the buccal pad of fat was teased out completely and then it is sutured well into its place. A picture showing a 1 week where the initial healing is completed. Another picture showing the healing after a month. Then after a 6 month where normal mucosalization has happened. Another case after excising of a fibrous band in a 34-year-old male patient. Okay, after it is done, it is usually sutured using a resorbable sutures, so it takes up nicely. So our experiences with the following cases includes with the cancer defects case of 4 cases, submucous fibrosis of 10 and oral complications 7. Here we could procure a mean size of around 1.2 by 1.5 centimeters. So the various cases where we tried was in well-differentiated squamous cell carcinoma and verrucous carcinoma and also in submucous fibrosis cases. Okay, the main advantages of the buccal pad of fat is that it has a good healing, as I already told you. Within a span of 3 to 4 weeks, the shrinkage of fat is noted. And when you observe the drooping of fat pad in initial site, you need not have to worry. As it heals, it actually heals along with the normal mucosal plane. So excess fat need not be trimmed at all. Okay. Many articles have been placed to illustrate the importance of buccal pad of fat. Okay, the volume depends upon the body weight and the fat distribution among the patient. It varies from individual to individual. So they found out that at least when you want to procure a glove or when the defect is around the retromandibular region, you can easily procure around 7 by 5 by 2 centimeters of successful reconstruction is observed. And if the patient is going for radiation therapy following surgical excision of a cancer patient, there is no any kind of a problem with that. So you can radiation doesn't alter or any problem to the tissue at all. The reconstruction can be carried out for low-grade malignancy. That's for the rapitis. And in case of maxillary reconstruction, the pedicle buccal pad serves as a good lining tissue at the maxillary sinus zone. So it heals without any infection at all. So basically, as you can know, because of a rapid healing and as the ability to epithelialize within 6 weeks, it can be used in various sites of the intraoral region from the palate to the retromolar trigone region. So the main problem with the buccal pad of fat or with buccal advancement over the buccal of fat is that it's a technique sensitive procedure. You need to properly procure the graft without perforating the capsule. Okay, or you can use the combination technique which was already illustrated by me in the previous cases. So minimal complications were noted except for trismus. The other complication being hematoma, partial necrosis of the flap, and excessive scarring. Sometimes the nerve, which is the facial nerve innervating the zone, during the procurement you can injure. So care should be done during the dissection process. So early immobilization is with a good blood supply, provides a good mobility to the patient. It has a good minimal donor side mobility, making it as an ideal flap. So it can be used in older patient to reconstruct the defects under the local anesthesia itself.